We'll get started. So we've done, Mike's invited me for quite a few of these. This is the first one that we're doing by Zoom. So I'm still learning, but I think I'm getting there. If I miss your question, I'll try to get to it. And I think Cyan and Victoria will be reminding me if I'm missing any of that. But
that is an important point. Just as a reminder for audience members, you can either use the Q&A, the chat, or raise your hand, and we will do our best to unmute you and bring you in. And then after this talk, there will be an evaluation survey so that you can give us feedback, give Dr. Weigand feedback. Usually this talk is very well received.
Thank you. Okay. And I was expecting one of my staff, Megan Wenner, staff audiologist, to join me, but I'm not sure. Maybe she's having some tech issues. So hopefully she'll come and join us and be my co-presenter. All right. So today we wanted to give some background about some new things that we're learning about in audiology. And if you've seen this talk before, you haven't seen it because it's very different if you've been in Dr. Reinhardt's group. So we really did made an effort to freshen it up and really make it current for 2020. So what we'll go through today, I'll introduce you to my staff. We'll talk about our roles as clinical audiologists. We will review some risk factors and comorbidities associated with hearing loss, discuss appropriate referral guidelines, describe a typical versus ideal patient journey, talk about some hot topics, and we'll talk about some applicable communication strategies for all healthcare providers. Okay. So as Dr. Reinhardt kindly introduced me, I'm the chief audiologist here in the hospital. Been here, just hit 20 years back in May. And I'm proud to say that we've treated over 50,000 patients during my time of being here and helped them to communicate better and feel more like themselves. I'm also a real person. I'm married. My wife's a speech pathologist. We met back in the last century. I have 2 teenage kids who are very into sports and now doing school partially remotely. So we're going to see what all of that's going to look like in the next couple of weeks. So I try to be very down to earth and real with my patients, and I take the same attitude when I give a presentation. So usually I like doing these in person because it becomes more of a dialogue versus me just saying stuff. So we'll try to keep that going even in the new format. I have 4 certified audiologists besides myself that work on my team, rotating through different addresses. And the reason that I show this is really just to let people know that we've invested a lot in training the right staff and also the right support staff to make sure that our patients have a good experience, to make sure that we can run a full service clinic that's open almost 50 hours a week. And I think it's important to know if you're considering sending your patients somewhere for hearing services that they're going to go to a place where the staff is equipped to be responsive to them.
Hey, Dr. Weigand, it's Megan.
Oh, hi, Megan. Okay, she's here. Yay. All right, very good. You ready to take this one?
Yes, absolutely. Nice to meet you all. My name is Megan. I'm one of the audiology residents. So just to jump off on what an audiologist is, they're healthcare professionals who provide patient-centered care involving hearing loss, tinnitus, vestibular issues, and other auditory disorders. This involves navigating complex medical, psychological, and social needs of the patient. And we have to maintain knowledge of all existing and emerging technologies, as well as interpersonal and counseling skills. And infection control is our new hot topic. Okay, but in doing that, we hope we are doing a lot more than just identifying and treating hearing loss. We hope to change the course of cognitive decline for patients, reduce their risk of falling, improve education, literacy, and employment, prevent social isolation and loneliness, reduce anxiety and depression, and decrease overall medically adverse events and hospital readmissions.
Okay, so some quick statistics. With every 1,000 live births in the United States, about 2 to 3 of those children have some degree of permanent hearing loss. Okay, this doesn't mean that they're deaf, but if we evaluated them, there would be a measurable deficit in hearing. 90% of deaf kids are born to hearing parents. About 15% of American adults report some trouble hearing subjectively. Age is the strongest predictor of hearing loss. 2% of adults between the age of 45 and 54 report disabling hearing loss, and this increases as we get older. And then men tend to have a greater tendency to develop hearing loss than women. So let's see if I can ask my first question of the crowd. So why is that? Let's see if I can ask and answer a question in Zoom. Can anyone give me an answer as to why that might be? Right, Dr. Reinhardt. It's because men typically work in noisy occupations and are more inclined to be exposed to noise in military service. Okay.
So some of the most common risk factors, like Dr. Wigan mentioned, are age. We're also going to look at any genetic components, noise exposure, and that can be occupational or outside of work. Medications can cause hearing loss and tinnitus, and systemic issues like diabetes and hypertension. Does anyone know a medication that can cause hearing loss? We would call these medications ototoxic.
Antibiotics?
Antibiotics, yeah, that's a great one. So a lot of antibiotics and like gentamicin and chemotherapies are probably the most common ones we see clinically. So the most common comorbidities of hearing loss are dizziness and vertigo, tinnitus and hyperacusis. We talk a lot about the psychosocial effects and the psychiatric comorbidities, including depression, anxiety, and loneliness, which we'll dive more into, and cognitive decline and dementia.
Okay, so loneliness is considered a health crisis throughout the world. Dr. Murthy was the former Surgeon General in the Obama administration, and he's published well-recognized research on loneliness. Statistically, loneliness impacts about 35% of adults that are over the age of 45. It is associated with premature death, and statistically, chronic loneliness can be as dangerous to your life expectancy as smoking 15 cigarettes per day. Okay, so as humans, we have basic needs: water, food, and people. Okay, just like we need the sustenance of water and food, we also need human contact and human interaction really to sustain ourselves. And for most of us, that's a motivator to keep going, is the human connection. The neurobiology of loneliness, chronic loneliness actually can lead to an increase in the function or responsiveness of the fight or flight nervous system, which can increase cortisol. Okay, as we know, that's a stress hormone, and that can lead to increased blood pressure, higher blood sugar, precipitating diabetes, and it can also negatively impact the immune system. So when we activate the sympathetic nervous system, again, there's an increase in cortisol. Chronic increase in cortisol affect the prefrontal section of the brain. That's the part of the brain that gives us our personality filters and judgment. And this can, over time, if it's a real issue for people, it can lead to persistently aggressive behavior, make the people seem distrustful, not fun to be around, and then also less attractive communication partners. And loneliness begets loneliness. So reduced social interaction can be associated with dementia, and then lower social interaction means that the brain is not tasked to the same degree. So there's less stimulation going to the brain. Loneliness as a medical condition. So what happens to the brain leading to neuronal cell death and dementia? So there are MRI studies that show that adults with chronic loneliness have decreased brain volume. And the hypotheses are that the damage from cortisol and potentially higher blood pressure have damaged brain cells. Maybe the lower levels of social interaction have reduced cognitive activity, or maybe distorted sound through hearing loss reduced access to the sound and led to the brain being less stimulated. And 20% of people with untreated hearing loss report chronic loneliness as well. Okay, so there was a study by Duzel from last year that looked at imaging and found that the correlation between loneliness and lower brain matter was measurable objectively. Okay, causes of loneliness, reversible and non-reversible. Non-reversible causes would be getting older, being female, right? Because the men die first, so we leave the women behind. Living in a rural area, having lower education, poor health status, and now maybe being in quarantine will lead to some loneliness. So those are conditions that are more difficult to manage. Situations that are easier to manage, typically if you have decreased hearing or decreased vision, these are medical conditions that are relatively easily treatable in most cases. Okay.
Oh, and we do have one question. What careers have the highest rate of hearing loss? I don't have an official statistic. Anecdotally, anyone who has worked in the military and other first responders, I would say, are high on my list of people that we see. And then here in New York City, people who work for the MTA are another big group that we run into.
Right. Thank you for that question. There was a study that I wanted to mention by Dr. Frank Lin, 2 words, hearing loss and cognition in the Baltimore longitudinal study of the aging. And he looked at the relationship between hearing loss and cognitive function. And the hypothesis was that a greater hearing loss was associated with reduced cognitive test scores on test of memory and executive function. So he looked at intersubject changes over the course of time, and his finding was that those people with greater hearing loss was significantly associated with lower test scores on measures of mental status. The reduction in cognitive performance was associated with a 25 dB hearing loss was equivalent to the reduction associated with an age difference of about 7 years. So if you had your identical twin who had the same hearing levels as you, and you were going through this study, and he had hearing levels at 25 decibels, and your hearing levels decreased to 50 dB hearing levels, it also had a correlation for you testing about 7 years older on your cognitive status tests. Okay, so there was a strong correlation there, and this is a study that got a lot of attention in our field of audiology, because it really gave some credence to the fact that early identification of hearing loss and early adoption of treatment was really in the best interest, not only for communication, but for cognitive and health status.
Okay, so just going back to some of our common comorbidities, why are hearing loss and dizziness or imbalance so closely related? And the first reason is geography. They share space, they share the 8th cranial nerve, and the fluids in the cochlea are actually also the same fluids that are in the peripheral vestibular system. Okay, so for that reason alone, we see a lot of overlap there. And additionally, people with hearing loss, even if they don't have a peripheral vestibular issue, are more likely to fall in general. And there's a correlation between the amount of hearing loss and the risk of falling.
Okay, so there's an example that we use in counseling. It says the hallway example. Just to shed some light on how much we depend on hearing to learn about our environment. If any of you walk down a hallway with like a pair of dress shoes that made noise, let's say in the hospital, and it was relatively quiet, if your eyes were closed, by the way that the footsteps would sound, okay, the changing quality of your footsteps, you would know if you were walking past an open door versus a closed door. Think of a blind person tapping a cane, okay, they do it to feel, of course, but they also do it to hear. And depending on their environment, the sound of that tapping will change. So we really do get a lot of information about the environment from hearing. Think also about someone walking next to you on the sidewalk and getting a cell phone call. Do they tend to walk slower or faster when they start talking on the phone? Right? Okay, so they tend to slow down. So that's a quick way to really realize how much cognitive effort is going into that conversation, hearing, listening, and processing, that it even slows down someone's movement as they're walking.
So some of the consequences of untreated hearing loss we've touched on a little bit, but to go into more detail, adults with untreated hearing loss experience 30 to 40% faster decline in their overall cognitive abilities and are more likely to develop dementia. 12% of people over the age of 50 report hearing loss that's significant enough to affect their understanding of their treatment plan, and that's from other physicians or healthcare providers. So this statistic is from a study that the American Geriatric Society put out, that this group of patients with hearing loss has a 32% higher rate of hospital readmission, and that can lead to an increase in the cost per capita of additional medical expenses that can be attributed to untreated hearing loss. Some of the benefits of amplification, because like we mentioned, this is a treatable condition and we can do a lot to help our patients. We're going to be able to increase their safety and independence, so they're able to be at home alone and hear the doorbell or hear the phone ring and not have to worry about it. They will have better communication and therefore relationships with their friends and family. They'll have better communication with their healthcare providers and have a better understanding of any follow-up plans or, treatment instructions they need to know. Patients with amplification have a reduced perception of tinnitus. There's evidence that it mitigates the effects of cognitive decline and that they have an overall improved quality of life. So who should be referred and when? If anyone has difficulty hearing in any situation, it's appropriate for them to get a hearing test. Sometimes we have a hard time, or our patients have a hard time saying whether they're having a difficult time hearing, but they may have other complaints like, I always want to turn the TV volume up and my wife is yelling at me about it. Or my friends, think there's something wrong. So they may have other symptoms that are leading us to believe that they have hearing loss. Additionally, if they have dizziness, imbalance, or vertigo, pain or pressure in the ears, any kind of tinnitus, which can be a ringing, a humming, a buzzing, a hissing, and if they have a history of noise exposure, all of these patients should be referred for a baseline hearing test.
Okay, great.
And when should they be sent to audiology versus ENT? So audiology, complaints of general hearing loss, tinnitus, reduced speech understanding, or any complaints of communication difficulties. And if they have more medical complaints like pain, pressure, drainage, or if their symptoms have a rapid onset, are unilateral, or there's a history of head trauma or acute infection, they should be sent to ENT first. But either way, they'll likely see both of us. It's just in what order.
Yep. Okay, so the typical patient journey, there tends to be a lack of awareness or denial when people first start developing a hearing loss. And only 30% of people with hearing loss use hearing aids. And that's not only in the United States, it's also true in other countries, even where hearing aids are covered at 100%, like in the Scandinavian countries. Preliminary audiologic evaluation. So quite often, patients are pressured by their family members and or a precipitating event to come in to check their hearing. A precipitating event is like they missed a flight or they made a mistake in a work situation because they didn't hear properly. So they're like, oh, no, I really can't put this off any longer. Lately, a precipitating event has been everyone around them wearing a mask and taking away the visual cues that were helping them get by, even when their hearing was less than 100%. People typically wait almost 5 years to get a hearing test after they first suspect reduced hearing. And they may have difficulty integrating or accepting the diagnosis of hearing loss. So there's a minimization, stigma, overgeneralization. They blame others, right? They say other people mumble, stop walking away from me when you talk, you're always talking to me when the fan is on. So they're blaming the situation versus acknowledging that it's a problem within them. And then quite often people wait about 7 to 10 years after their first diagnosis to get hearing aids, okay? So there are a lot of factors that will also go into someone's decision to move ahead with getting hearing aids. Insurance coverage, we have seen as of this year, the Health First and United Healthcare benefit for hearing aids from the patient's viewpoint has actually improved. So most of those patients can get at least something very basic at no cost to them. There are some insurances that require cost sharing. There is, people have to also accept that they see themselves using hearing aids, right? So any decision in life we have to make at least twice. We have to make it internally, we have to see ourselves doing something, and then we actually have to take the step to do it. So something that Megan and I ask when we take a case history, especially on a new patient who's having complaints of hearing loss, if this exam shows that you could benefit from hearing aids, is that something you can see yourself doing? So we want to put it out there right away to get their mind going that that's a possible outcome, a possible recommendation for the appointment. And then patients have to also commit to coming back for the necessary follow-up. If you own a car, you have to take it for service. If you own a set of hearing aids, you also have to bring them in for service. We recommend after they're done with their adjustment period, which is usually the first 6 weeks, that they're coming in at least 3 times a year. One of those appointments would be a hearing test, and the other 2 would be for checkups and maintenance. Okay. The ideal patient journey is that people would have regular hearing screenings as adults. They would be referred by their physicians. After a failed screening, they would bring a companion, their communication partner, so that we can educate more than one person about what's happening. They would be open-minded to the diagnosis and recommendations. They would agree to try hearing aids. They would return for the follow-up with questions and request the proper services, hopefully report benefit, and then return for their maintenance, as we said. It's just as important. There's a commitment to ownership as well as just taking the first step, okay? So some hot topics in the news in audiology, COVID-19, the demographics of aging, Medicare and insurance coverage, and then over-the-counter hearing aids, okay? Has anyone seen these clear masks around? Maybe.
Or the face shields.
Yep, we ordered some in the office. Sometimes we do go to the face shield when patients really need the visual cues to hear us. So it's something to be aware of as practitioners, people dealing with patients, that without them seeing your face, some of them may be working harder to try to hear and understand. Okay. There was a study that looked at the correlation between hearing and vision, and this actually came out before mask wearing in 2017, and they found that people with good hearing focused more on the upper half of the face, whereas people with hearing loss focused more on the lower part. So, I mean, it's pretty intuitive to draw that conclusion. It is something that was actually studied and published in 2017. Okay, Megan?
So, yeah, apart from the patient's ability to read lips or do any kind of speech reading and use their visual cues when people are wearing masks, we also have to think about the physical challenges that can happen, and we're seeing that more and more in our clinical practice, where patients have a hearing aid, a mask on, and oftentimes glasses as well. And there's physical difficulties that occasionally crop up.
Right.
So,
I just made a note to myself to add a mask strap slide. So this is a mask strap, if you can see it. So this goes on the back of someone's neck, not on the front. I'm just doing it to show you. And basically what it would allow is for the strap of the mask to be looped here so that the person can wear it under the ears. So sometimes we start the appointment by giving the patient the gift of a mask strap, and they're like, oh, you just solved a problem that I didn't even get to tell you about yet, because that was like on the top of their list now that the hearing aids don't fit. And in the last couple months, we have been fitting more of the custom hearing aids that fit more like an earplug, that go right in, that don't have anything over the ear. So they're resurging in popularity, especially with mask wearing.
So also an interesting article that came out just a couple months ago was the airborne lifetime of speech droplets and their importance in novel coronavirus. And this study found that, well, the study also relied on a previous article that was published, which linked patients with hearing loss speak louder and therefore create more speech droplets. So this second article listed is sort of the foundational piece, and then building off of that, in patients with hearing loss who speak louder and produce more speech droplets, is there an increased risk for coronavirus transmission? That's still up for debate, but people who speak louder than the average conversational volume, which could be a person with hearing loss or their communication partner who needs to speak louder to be understood. Those speech droplets are aerosolized for anywhere from 8 to 14 minutes, and that's in a still air room, but something really worth thinking about, that it's not just for a minute, it's for 8 to 14 minutes. It's in the air.
Mm-hmm. Okay. Oh, you ready?
Yeah.
Okay, got it. Okay, so how have we pivoted as a team? I actually did a home visit this morning, and we have done more home visits, especially during the shutdown. People were so happy that we were still answering the phone. We had a lot of people that needed to have their hearing aids checked, or they had hearing aids that were in the pipeline that we wound up delivering. We are able to send out supplies and batteries through the mail. We've been in touch with a lot of patients, just calling them, just seeing how they're doing. And I had a gentleman call me, or rather I called him, and he was so happy. He said, you know, sometimes a phone call is better than any medication. And we really just wound up chatting for 10 minutes, but he really was so happy to have that human connection, just to have someone reach out to him. Some of the technology that we work with, some of the hearing aids, they pair to smartphones. And in some cases, we can access an app in the patient's phone with their permission that would allow us to actually adjust the hearing aids remotely.
So another hot topic in every field of healthcare is the aging population. Baby boomers have a longer predicted lifespan than any other generation, and they view themselves as younger than they actually are by about 10 to 15 years. By 2035, so in just 15 years, the US will have more people over the age of 65 than under 18. And most baby boomers are fairly health conscious, and they are pretty strong advocates for themselves. They generally want to age in place and feel young and with it. So as we see this aging population increase, we are also expecting dementia rates to increase. So in 2016, the global number of people with dementia was up significantly from 1990. All right, and currently 5.8 million Americans are living with Alzheimer's. This number is projected to rise to 14 million by 2050. And like we talked about before, hearing loss has been found to be associated with accelerated cognitive decline, although of course we can't say that there's a causation.
Okay. Right, so it would be irresponsible for us to say that if someone gets hearing aids that they're not going to get dementia. But what if a person has cognitive decline, cognitive impairment, and hearing loss? At least treating the hearing loss will make it easier for that person and their caregivers to communicate during such a critical time. Okay, and it's intuitively we could say that if we can take the effort of listening off the brain will have more of a reserve to focus on retaining information and really just being less tired at the end of the day and focusing on everything else that has to happen around them. Okay, so here's a question. Is Medicare non-coverage of routine hearing exam a form of age discrimination? So many of you know that about 20 years ago, universal newborn hearing screening became mandatory, and it is mandatory now in just about every state. Okay, I was on the design team for that program here at the hospital when I first started out. And then it's recommended that children receive hearing testing periodically throughout life. Unfortunately, Medicare does not require routine hearing screenings, and they won't even support it financially. Okay, right now, in order for us to get paid to do a hearing test on a Medicare patient, their physician has to write a prescription, which is supposed to be complaint driven. So a physician is not supposed to say to a patient, hey, by the way, you're of retirement age, why don't you go get your hearing checked? The person is actually supposed to complain to the physician and be proactive about it, or the physician is supposed to notice that something is wrong. So the concept is that why is it okay, let's say for a person of retirement age or older, to have an undetected hearing loss, okay? And the reason I say is it okay is because Medicare is saying they're not going to cover it. They're not going to cover routine testing, but it's not okay for a child to have hearing loss. So maybe it's a form of age discrimination against seniors. Okay, this is an audiogram. Whoops, sorry. Okay. Sorry, Megan, oh, go ahead.
Oh, yeah, okay. So oftentimes when we give these presentations, people ask for us to walk them through an audiogram, so this is a good example of that. So across the top of the graph is pitch, low to high, like a piano. And on the vertical axis.
Sorry.
That's okay.
I broke it. Can you see it?
Yep.
Okay, sorry about that.
So on the vertical axis is going to be loudness. All right, so soft sounds to loud sounds. The red and blue
just as a
are
heads up, though, it's not in presentation mode.
Yeah, I'm sorry. Okay. Thank you. Okay.
Perfect. All right, so the red and blue circles and X's are for the right and left ear. So this is a plot of the softest level a person can hear for each different frequency for each ear. Normal for an adult is 25 and better. All right, so we would want all the symbols at the top of the graph. Okay, so this person has hearing loss because some of their symbols are falling below that 25 mark, and it's sloping down to moderate hearing loss. Okay, so the question is, would our recommendations be any different if this was a 10-year-old versus a 75-year-old retired person? Ideally, there shouldn't be any difference, but realistically, if this was a 10-year-old, alarm bells would be going off, everything would be shut down until a plan was in place for this child. And most 75-year-olds, we would explain this hearing loss to them, and they'd say, well, it's normal for my age. I'm not really worried about it.
Right, but the fact is, there really is no such thing as normal hearing. For your age, either you have normal hearing or you don't. We meet people who are 75 who do have hearing levels in the 10 to 15 decibel range across the board. Not many of them, but they're out there. And then unfortunately, we meet babies with hearing loss. So either you have a hearing loss or you don't. Okay. Hearing aids and cost sharing, we touched on this a little bit before. So as of 2020, Health First and United Healthcare are covering generic technology at no cost to the patient. Standalone Medicare does not have a hearing aid benefit. Private pay, the average cost, what people are spending per hearing aid that they're going to use, typically between 4 and 5 years, is about $2,300 per device. So if you have those hearing aids and the services of the audiologist for 5 years, you're looking at about $20 a week to treat a chronic medical problem, okay, which is quite often less than they would pay copays for medication. And on this campus, about 6 out of 10 patients are receiving hearing aids and services at no cost to them. It's covered by insurance. Personal sound amplifiers and over-the-counter. So by the end of this year, the FDA is expected to make an official ruling on over-the-counter hearing aids, which in truth have always been available. There have been ads in the back of magazines or online for people to get basic hearing devices, and that's since before I was in this profession. In general, hearing aid users do report a high level of satisfaction. 83% of hearing aid users report that they were satisfied and that they would also recommend hearing aids and their provider to a peer. Okay, and when we treat a patient, we're looking for a long-term relationship. We're not just looking for a patient for that day. We're really looking for a patient for life. 72% of people not using hearing aids say that they would consider purchasing a hearing aid online, and 38% said they would want the technology plus the professional services. I don't think people realize how important the involvement of a professional is until they really start the process. And Megan and I see patients almost on a weekly basis that will come in because they've purchased a hearing device of some sort online and they need help using it, or maybe it isn't meeting their expectations. We embrace those patients because they've already taken the first step. They know that technology is something that they need in their life and they're open-minded to it. Different patient experiences. These are real quotes that people have told me, and I did want to share these with you. A patient not too long ago, she said that people at her church, they shun her because she doesn't hear well and it's difficult for her to communicate with. One of my front office was confirming an appointment, and she was on the phone for about 10 minutes, and the person on the other end said, you know, I'm sorry for keeping you on the phone so long just to confirm this appointment, but you're the only person I spoke to today. So I think a lot of our patients do have loneliness that maybe we're not aware of. Some people say that they have to force themselves to hear. Sometimes people tell us that if their family member has to repeat themselves several times, the family member gets frustrated and then they say, oh, well, it's not important. And the person with the hearing loss then feels that they are not important enough for their family member to communicate with them. A little girl that was fit with hearing aids, after she really started benefiting from the treatment, she said she felt like a real little girl. Some patients tell us that their family's fed up with them. And then the last one, okay. And then, a misunderstanding if you think about how some words would sound alike. Instead of Michelangelo painting the Sistine Chapel, you might think that he painted the 16th Chapel. That would be an error that a child could make if they weren't hearing well in class. A colleague of mine told a story at a conference earlier this year. The patient herself is a senior who wanted to be a compliant patient. She had been taking ibuprofen to manage some pain, and then she was advised to stop taking the ibuprofen and move over to Celebrex. but because she didn't hear the instructions well enough, she took both of them together, and it caused a GI bleed. She wanted to be a compliant patient. The result was that she lost 25% of her blood volume. She became anemic and then required multiple procedures to regain her health. And that was really because she did not hear well. She did not hear well and adhere to the physician's orders. Okay, ultimately, this colleague, she happens to be a physician. She took her mother to get hearing aids. They went to a restaurant and they reported that family members were getting back to a normal way of interacting with the patient. The patient's overall demeanor changed. She was smiling. She was more energetic. She stopped talking about being at the end of her meaningful life and also stopped talking about taking her life. So the perception of my colleague is that the treatment by the audiologist had a life-saving effect. It was a remarkable experience, and it resulted in a high level of trust between the patient and the provider. So what I try to teach my students is really to think, is really to think beyond just evaluating and assessing the hearing loss. Don't only look at the patient, look at their support system, look at who's behind them, look at who is depending on them to stay in the game and be a good communicator. And this is something that we have to be aware of, not just as audiologists, but really as any provider dealing with these patients. Okay. So cousin Bob, he's real. He's my mother's cousin. He's a few years older than mom, so early 80s. And he would come over to the house when I was growing up or come to the family reunion, and he would say hello to everyone. And he would always have a book or a newspaper, and he would find a corner and go and read his book. And when I was a kid, I played with the other kids, and I didn't really care too much about cousin Bob because he was off by himself. And what we realized over time is that this was his way of coping with not hearing well. So he would technically accept your invitation. He would be in attendance, but he was not really part of the group. Ultimately, he lives out in Jersey. He goes to the VA for treatment. He wound up getting a cochlear implant on one side and has a hearing aid on the other because his hearing is to that point. And he's doing much better. But quite often, people do step back from interacting when they have a hearing loss that's really putting a challenge on their life. So it's something really to be aware of.
So some takeaway communication strategies for healthcare providers. The first is to make eye contact. And it is hard now that we're all having to wear the masks, but even making eye contact does improve people's understanding. Use verbal verification of your instructions. So if I was told to, stop taking this medication and start taking this medication, I would repeat that back to my provider. This is what you've told me to do. I understand. Give information in writing as often as possible. I know a lot of places give, a summary sheet of the visit for the complaint, the diagnosis, and any instructions and follow-up plan. And if possible, communicate with a companion or caregiver. Hopefully that person has someone with them. And that 2 years are always better than 1.
Okay, great. So a little bit about the hearing aids that we're fitting today. A lot of them connect to smartphones, so they're becoming devices that not only help people hear better, but also enhance their lifestyle. And some features of hearing aids are features that we're seeing in general wellness products, like Bluetooth compatibility. Some hearing aids even give a step count. And then there's one technology out there that records the time of listening to a live voice. So it gives the patient a social engagement score at the end of the day. And it's a way of the provider and the patient really to look at how much social interaction the person is having. That same type of hearing aid also has fall detection technology in it and optical sensors that can measure heart rate and steps and social engagement. There is some talk about microphones in hearing aids monitoring voice quality, and there has been venture capital investment in looking at studying voice quality and speech patterns as related to certain medical conditions. Okay, so if you think about someone who has a concussion, they may be slurring their words, elongating sounds, and have variations in their nasality of their voice. Think of someone with mental illness. If they are depressed or in a manic state, their rate and the energy of their voice will change. And these are all things that are measurable, even though I don't think they're being widely used yet in diagnosis.
So a few myths and misconceptions. Hearing aids will restore my hearing just like I put on glasses and my vision was corrected. I wish that this was the case. My job would be a lot easier, but it's not. It's not quite that easy. So oftentimes we use the example of someone having a knee replacement and going to physical therapy. You could have the best titanium knee, the best surgeon out there, but if you don't go to physical therapy, you're not going to do very well with it. So the same is true for hearing aids. You can have the best technology, but if you're not committed to wearing it a significant number of hours per day and continuing with your follow-ups, people can run into issues. And we do try to impress on all of our patients that, especially at the beginning of their treatment plan, some adjustments might need to be made and they might come into the office a couple of times. And usually people wind up being much happier long-term when they do that. Okay. Another common thing we hear that we touched on is that my hearing is normal for my age. So a lot of times older people will get diagnosed with hearing loss and they kind of brush it off and say, well, it's, I'm 80, what do you expect? And to that, just like they have arthritis maybe or high blood pressure, those conditions are all common in people who are older. That doesn't mean it's a normal state, and it doesn't mean you wouldn't treat it. Okay, so hopefully, that conveys the message to them. People often think they can get by with just one hearing aid, even if they have hearing loss in both ears. And that one's pretty easy. Not many people wear a monocle these days. So there's a reason we have 2 ears, and there's a reason that we would recommend 2 hearing aids. And a lot of times people worry that a hearing aid could make their hearing worse, especially if they have a history of noise exposure. That might be on their mind. We, as well as the manufacturers, work very hard to make sure that a hearing aid would never be damaging to the patient's residual hearing.
Right. One of the examples that we use in counseling is that when patients come back for their fittings and follow-up, it's like having a musical instrument tuned. Making it louder doesn't just make it better necessarily, or if they went for a suit or a dress, they would have to go a couple times to get it tailored. So most people can relate to that example when we explain that the follow-up is so important.